Do I need to get a transplant after induction therapy as consolidation if I'm transplant eligible?
After induction therapy, for a transplant-eligible patient, oftentimes they'll have their stem cells collected and then proceed on to autologous stem cell transplant. It's really not a transplant, it's a rescue because the current high-dose therapy regimen for autologous transplant is melphalan, and melphalan is very toxic to normal bone marrow. So you need this rescue of the patient's own cells. So again, it's not really a transplant.
In an autologous stem cell transplant, you collect and freeze your stem cells. You then take a high dose of chemo, usually melphalan, which wipes out your immune system and hopefully the myeloma. You then unfreeze your immune cells and have them infused back into your bloodstream. So you are your own stem cell donor, which is why it's called an autologous stem cell transplant.
So if the question is whether induction therapy needs to then be followed up with a stem cell transplant or sort of consolidation course, if you will. In my mind, no. I think the goal should always be an intensive bout of therapy, get the disease under control, put out the fire, if you will, and then you want to decrease intensity to a maintenance phase. Now, in the younger fit patient, that may include a consolidation with high-dose chemotherapy and stem cell transplantation before maintenance therapy. But in an older patient, I still think that the goals remain the same. Get the disease under control, ideally remission, then back down to a maintenance strategy that's going to keep the disease under control as long as possible without it causing any more end organ damage.
If I'm transplant eligible, do I always need to do transplant up front after induction therapy, or can it be delayed?
The big question is, can you defer this, or can you not ever get this high-dose therapy? And that's been a question that keeps coming up every few years, especially with the advent of novel therapies, because we have much better responses up front, and how can we maintain those responses over a prolonged period of time? So, at least for a large number of patients, induction therapy, stem cell collection, and then transplant is the standard. You could delay, but I strongly recommend that the patient have their stem cells collected up front, because if the patient's getting a lot of therapy, it might damage the stem cells if they are collected after a prolonged period of treatment.
So even if you don't plan on doing an autologous stem cell transplant, get stem cells collected early so you can keep it open as an option.
The problem with delayed transplant is that sometimes the patient may get too sick or have a very aggressive relapse and not be able to get to a transplant, not a second transplant, but a first transplant. And so that is one concern. Depending on the study, anywhere from 20 to 40% of patients don't get that transplant because it was delayed. And so that is one concern. We need to understand more about that. But it at least is an option. What was most recently reported at ASCO 2019 is that the patients who got KRD, which is carfilzomib, lenalidomide, dex for 12 cycles, versus those who got a KRD induction and then a stem cell transplant and consolidation with KRD, the KRD transplant patients at 1 year had a higher rate of being minimal residual disease negative. And that was seen primarily in the higher risk groups, revised ISS, International Staging System, revised ISS 2 and 3. So those patients benefited from getting high-dose therapy with melphalan and the stem cell rescue up front because they had a lower relapse rate than those who got KRD times 12. So this is a very early read, though. We're not sure how this will translate into long-term progression-free survival. So the good thing is we have lots of options for our patients. The only problem is these new drugs are making our patients respond so well. We have to leave studies open for years to figure it out. And then we get a new drug and we're figuring out, well, how do we study this? These are all good problems to have. These are great problems to have for our patients. It's tough to figure out how do we place it all, and that's the only problem, but it's a great problem for our patients.